Pankaj sir, please start. Thank you. Sir, kindly unmute yourself. Kindly unmute.
Okay, thank you, ma'am. Am I audible? Yes.
Yes,
Okay.
Pankaj.
Yes, before I start my session, I would like to take this opportunity to thanks all the teachers and gurus present over this esteemed platform for making all of us the better academicians and better people in life. So thank you to all my gurus and all my teachers. And good evening and Eid Mubarak to all the dignitaries present on the dais and off the dais for the very important vaccinology series by Maha IP under the guidance of our beloved Dr. Nitin Shah sir. I request Dr. Sanjay Pakmode sir, President Maha IP, for his welcome address. Sir, Dr. Sanjay
Thank you,
Pakmode.
Pankaj. Thank you, Pankaj. Namaskar. So, once again, the blockbuster episode of Vaccine Samvad. Today, sir has planned the vaccine, the rabies vaccine. First of all, let me welcome all the teachers and wish them a very happy Teachers' Day, because of which their guidance and the path they have shown, we have moved ahead. We have rather learned so many qualities from them. Each one had a unique quality, and we inculcated those qualities in us so that we can follow their path. At the same time, let me wish a very happy Eid Mubarak. Eid Milanadubi. Now today's, as sir has, sir is already always choosing the vaccine according to the season, according to the attendees' point of view. Just before the starting the program, the service to why the sir has chosen the particular rabies vaccine. Because the first time the dog lovers has changed the verdict. On the 11th of August, the one verdict came, and on the 22nd August, the another verdict came. In just a span of 11 to 12 days, in Supreme Court has to change the verdict in favor of dog lovers. So there is a fight between the dog lovers and the people who are affected by the beaten dogs. Hence, the responsibility lies with us. Whether whatever be the scenario, we must know what is the rationale of giving the rabies vaccine, the appropriate treatment of the rabies vaccine. Because if we are not managing or we are not giving the vaccines, then we know what can happen with the patients. And to prevent this, we must know each and everything about the rabies vaccine. So this vaccine is a very favorite. So many queries. Dr. Marathi always says he's getting almost all the time phones for the rabies vaccines from the periphery. And the purple book, Dr. Marathi has written a good chapter on it with Shunai sir. So I welcome all the stalwarts panelists for the today's particular Vaccine Samvad. Dr. Khadke sir, Dr. Sanjay Srirampurkar sir, Dr. Anurag Agrawal sir, and our vaccine doyen Dr. Nitin Shah sir. I welcome all the OBs and EBs of Maha IP and CIP on this wonderful Maha IP platform. And again, the one more thing with this rabies vaccine, recently the one kabaddi player, national kabaddi player, he was a state level golden player, Brijesh Solanki, died of because he was beaten by a stray puppy dog, whom he rescued from a drain. But he neglected that particular injury and didn't receive the anti-rabies vaccine, and he died within a span of 1 or 2 months. Just a 20 years, a very promising career of that particular player. So such is a thing with the rabies. And I always remember, Nikhil always says we have saved one case of rabies. So there are, I think sir will tell us how many cases reported of proven rabies after treatment. So let us know from all our stalwarts today in depth the information about the rabies. Thank you. Over to you, Pankaj.
Thank you, sir. Thank you for your wonderful welcome remark. Now I request Secretary Maha IP, Dr. Amol Pawar sir, for his welcome address.
Thank you, Pankaj. First of all, on occasion of Teachers' Day, happy Teachers' Day to all the teachers present over here. I welcome Dr. Nitin Shah sir, moderator of this session and the main person behind this Vaccine Samvad of Maharashtra IIP. And also I welcome all the speakers who are who's who of IIP in vaccinology. My dear friend Dr. Anurag Agrawal sir from Delhi, then Dr. Rajendra Khadke sir from Aurangabad, and my guru Sanjay Sharampur sir from Hyderabad. Basically, he is from originally from Maharashtra, and all the dignitaries of Maharashtra IIP as well as various office bearers of district branches of Maharashtra IIP as well as uh, all the attendees, delegates, students from all over India actually, because this is a very special session on rabies, and in last 2 to 3 months, Delhi has been hit by various rabies cases, and there was a lot of debate going on with bureaucrats and all the government authorities plus pediatricians and all physicians hear from all the experts about rabies. And I also welcome Dr. Ganesh Kulkarni sir, our dear friend from Chhatrapati Sambhajinagar. Then Dr. Sagar Wag sir is there, and Dr. Ravindra Sonone sir is there, and Srinivasan sir, who is always there as a delegate in all the Maharashtra IIP webinars. He is attending it since beginning, or I will tell since last 3.5 years. He is in USA most of the time, and he always take it a point that he attends all the Maha webinars. So over to you, Pankaj, for further proceedings. Thank you.
Thank you, sir. Thank you. Now I request Convenor Maha IIP, Dr. Sanjay Deshmukh, sir, for his welcome address. Dr. Sanjay Deshmukh, sir.
Good evening. Firstly, wishes of the festival surrounding Onam, Ganesh Chaturthi, Eid, and above all, happy Teachers Day to all our respected teachers who taught us so years. And Vaccine Samvad is one of the platform, even if in festival season, the scientific session must go on. And hats off to Dr. Nitin Shah sir and Maha team who continue this academic legacy every month on first Friday. I welcome our esteemed faculty, Dr. Anurag Agrawal sir, Dr. Srirampur sir, and Dr. Khadke sir to Mahape platform. And I hope today's discussion on rabies vaccine will make sure we have to think retrospectively on the recent scenarios. So prevention is better than cure, but how to go and how to clear the confusion. So over to Dr. Pankaj and best wishes.
Thank you, sir. Now, before we proceed for the discussion on rabies vaccine, I would like to briefly introduce the esteemed panelists and moderators for today's session. So first, I would like to introduce Dr. Nitin Shah, sir. Sir is the past president of IIP 2006. He is the section head at Hinduja Hospital, and he is an hemato-oncologist at BJ Wadia Hospital. Sir is author of several textbooks on oncology, hematology, and immunology. We welcome you, sir. We have three esteemed panelists today with us. First one is Dr. Sanjay Srirampur, sir. He is an ID and vaccine expert from Hyderabad. Sir is an academic head at Rainbow Children Hospital, Hyderabad, and he is the member of immunization committee at various different time frames. He is the joint secretary of CIP 2009 and organizing secretary of Pedicon 2010. Our another panelist is Dr. Anurag Agrawal. Sir is a professor at Maulana Azad Medical College. He was EB member CIP 2021 and 2024, and he was the member of ACVIP from 2024-2025. Sir is the founder secretary of Consortium Against Rabies. We welcome you, sir. Our third panelist, Dr. Rajendra Khadke, sir. Sir is a senior pediatrician and director at Vasad Medical Foundation, Aurangabad. Sir is a pioneer in pediatric critical care in Marathwada region, and he is a course coordinator for immunization module of AAP. Sir is an ACVIP member of 2021-22, and he is a faculty for various national and state conferences of IIP. We welcome you, sir. Over to Dr. Nitin Shah, sir, for the further proceedings.
Well, thank you, Maharashtra IP, Dr. Pakmode, Amol, all the people who are there, Minaz, Dr. Pankaj Agrawal, for yet another opportunity for this Vaccine Samvad. This is the 9th in the row, and we've been doing on the first Friday of every month. And the next will be on the 3rd of October, that's just the day after the Dashera. And this time we will take the topic as adult vaccines, because I think we are protecting children with vaccination. We forget that we also need vaccine for adults, and that will be a very exciting session as to what to do. Now, talking about rabies, why I chose it, a very funny incident, Dr. Anurag. 5th of August 2011, a flight was to take off in USA, and suddenly one bat entered from the door and made some 100 sorties inside. Everyone was helter-skelter and suddenly disappeared. Now the question was, is anyone bitten? Because bats can lead to rabies in silver hair. Bats can lead to rabies in USA. That's the problem in USA. That's the only, in fact, rabies they have. Most of the animals don't have rabies there. And CDC was contacted. The flight was cancelled. Entire people, including crew and those 300 plus the Pravasis, they were actually screened for bites. And they were offered that they can take a vaccine if they are having fear that whether they could have got a rabies exposure. So such is the in the mind problem. I will give you another example. I had a phone call from one general practitioner. He says, one dog came next to me, brushed my pant and went away. No, I don't know whether he's bitten me or no. I say, I'm very worried. I'm very worried. I say, if you're worried, take the vaccine. So I think my beginning sentence and my bottom line at the end is that when in doubt, give the vaccine, because there is no cure. And in fact, we have had one or two survivors of rabies in Hinduja Hospital after prolonged stay with Dr. Udani's treatment, and we used to that Milovic protocol. But it's a horrible disease to survive. I mean, sometimes you feel you better die rather than survive of rabies. So, with that preamble, let's start today's discussion. I will first open with my Maharashtra colleague, Dr. Khadke. What is the rabies burden in the world and in India in brief numbers, so that we know why are we talking about rabies in India?
Sir, at the outset, I must thank IAP for giving me an opportunity to share dais with all those three stalwarts in the country. Coming to the question, basically, we have statistics of 50 to 60,000 annual rabies death across the world. But at the same time, 1/3 of the deaths are occurring in India. And 40% of the children less than 15 years are affected.
Correct.
So that's a huge burden in India.
Correct. And this is a mortality. I mean, the number of exposures will be in millions. And in fact, if you look at the use of rabies vaccine, not even 10 or 15% actually reach a destination to take the vaccine. Dr. Anurag, will you like to say something about the incidence of exposure? I mean,
Sir, the annual incidence of dog bite is 2.5%. That means 2.5% of population is bitten by dogs. So we did a survey in 2016, and the recent survey done also showed similar incidents.
That's like 4 crore exposure. And how many actually take the vaccine?
Hardly 60% take the vaccine because they
Correct.
don't report, remaining don't
Yes.
report.
And less than 10% take the monoclonal or the rabies
Yes,
immunoglobulin.
the data shows that around 5% take the rabies immunoglobulin, and the remaining, around 50 to 60% take the vaccine.
Correct. So you can imagine why deaths happen. And of course, we have had a spate of deaths in people who have taken the correct post-exposure prophylaxis. We will discuss that at the end if we can get time. But that brings me to Anurag. How is the rabies transmitted? I mean, people need to know that what is this incubation period and how it is transmitted.
So there are two major routes of transmission. One is biting. So we all know that bites can lead to rabies. Second is scratching. Earlier, there was a lot of discussion that do scratches lead to rabies? The rabid animal drools. So when it drools, it licks its paws, and those paws will contain saliva and will lead to rabies.
Correct.
Then there are uncommon routes like organ transplantation.
Mucosal before that. Mucosal exposures.
Yes, sir. Mucosal exposure can lead to rabies. That will again be a bite or a scratch. So we are classifying it into bites, scratches, the common routes, then the uncommon routes like aerosols, ingestion like milk, and sexual transmission and organ transplantation. So these are the routes which need to be looked at, because
that's the reason why organ transplant from someone who had a neurological problem before he became pregnant is not allowed. Because he could be having a dumb rabies as an adult. And so that's why cornea transplant has led to, in fact, in past, some cases of human rabies, That's the reason why
So,
we don't allow.
yeah,
Yes.
around 20 cases have been reported from
Yes.
China, from US, from Iran, multiple countries. There was a list published around
Correct.
2 years ago. 20 or
Perfect.
more cases because of organ transplantation.
Correct. So, Sanjay, now the question is that people need to understand what is this entire post-exposure prophylaxis. I mean, God is kind that He gives you time to take post-exposure prophylaxis and almost 100% do away with rabies in spite of you having been exposed to a rabid animal. Well, it all depends on the incubation period. And there are some report where say there was no dog bite or any cat bite and still rabies happened. Or there was a dog bite 2 years back, 1 year back, 6 months back, and rabies happened. So what is all this incubation phase? Can it be so short and so long? And what happens when someone, Sanjay, you need to unmute yourself.
Yeah.
And what happens when someone develops rabies? I mean, how does the virus transmit and what does it lead to, basically?
Basically, the incubation period of rabies is very variable from a period of weeks to months.
Correct.
That depends upon the dog or the animal which is biting. That also depends on the site of the bite. That depends on the inoculum. That depends upon the individual.
Correct.
This is as far as the incubation period is concerned. Now,
What happens when someone is bitten and it's a rabies virus enters? Now what happens?
Yeah, the interesting part of rabies is that it's not an immunological disease, it is by neuro invasion. So whenever a person is bitten with a dog, the rabies virus enters the bloodstream, then it is transported through the peripheral nerves into the CNS via the spinal cord. Then there's hardly any immune reaction there. It's
Okay.
mostly because of neuro invasion.
All right. So, Dr. Anurag, I'll come back to you. What is the longest so-called incubation period patient you have seen? Because I see you have some 20, 30 patients every day, and for months and years you are doing it. So, what is the longest incubation? Known incubation. I mean, if this no one knows, then we don't know what can happen.
So actually, sir, the problem is that a lot of times patients come to you that they who develop rabies and say that they were never bitten by a dog or cat. So we do not know the longest, but maximum cases occur between 30 to 90 days.
Correct.
Less than 1% cases occur after 6 months.
Correct.
And incubation period of years has been known. There was a report 20 years later he developed
Correct.
rabies, was bitten by a dog. So we do not know.
But
yes,
could
that
it
is
be
very
that he
important.
actually had another exposure which he doesn't
Yes,
remember,
yes,
and the blame goes to the
yes.
old exposure? All right. What is the
Yes.
shortest incubation you have seen?
So I
7
have
days,
seen
10
20
days?
20 days,
20
15 days, 15 to 20. There was one case who
Ah.
developed rabies before the 4th dose.
Correct. So if you have 15 to 20 is the shortest, and generally beyond 20 to 30 days
Bite on the face.
is the entire fulcrum science behind post-exposure prophylaxis. There you give vaccine after exposure and develop a protective antibody by 2 weeks so that the virus, even when it is entered, does not lead to rabies. And in class 3 bite, you give it locally also so they don't allow the entry of the virus. I think this is a basic funda people should understand, and that's why don't shy away while giving the local treatment. Okay, Dr. Khadke, what happens in rabies ultimately? I mean, what is it? Where is the site of infection? Is it neurotropic or is it encephalitis? What type of encephalitis?
As already been explained by Srirampur sir, from the local site of bite, the viruses, they traverse from periphery to the center.
Correct.
From peripheral nerves to the central spinal cord to central, and there is a neuroencephalopathy which has occurred, which would occur. There are two types of presentations which we can really get into the clinical practice. One is a furious type and second is a dumb type.
Correct.
80% to 90% is furious type,
Correct.
where you will have symptoms of hydrophobia, aerophagia, then you have photophobia,
Correct.
and the child could be absolutely mad, or the animal which has been bitten would be absolutely mad and go on biting somebody. So it's a furious type of a presentation, which is almost in 80 to 90% of the children. But in 10% of the children, you can have dumb variety, where there is no bite, there is no madness, but at the same time there is some paralysis which is occurring, from ascending paralysis from lower limbs to the upper limbs, and in both circumstances basically the death is because of the cardiac circle as well as respiratory failure.
So basically, rabies is a disease of brainstem encephalitis, and because the brainstem is involved, the respiratory, cardiac, apnea, blood pressure, everything gets haywire. But because the higher centers are not involved, the patient unfortunately is completely alert till almost the last
Till
few
death.
hours.
Till death, the
I mean,
patient is
that's
alive.
why it's the most painful death in that sense that you
Yes.
can actually get. Unlike other causal JE or other viral encephalopathy,
Yes,
where the
sir.
patient is obtunded. But in dumb paralysis, all the symptoms may not be there. So it may behave like an edema or one of those type of syndrome which can be there. All right, Sanjay, what is dumb rabies now in animal or only also in adults? I mean in humans.
In
And how do you
humans,
diagnose that this is dumb rabies if there are no symptoms?
generally, as Dr. Agarwal said, sir said that rabies in 80% of cases is furious rabies, and furious rabies selectively affects it is neurotropic for the brainstem.
Correct.
Whereas dumb rabies is that sort of rabies which can happen in 20% of individuals, and that affects, it's an myeloradiculopathy.
Correct.
It's an ascending myeloradiculopathy. And what is very interesting is that it can mimic Guillain-Barré syndrome.
Exactly.
It can mimic Guillain-Barré syndrome. And the
Correct.
second most interesting part of it is that it starts, we need to suspect dumb rabies whenever somebody has got paresthesia at the wound site and
Correct.
early bladder and bowel involvement.
Correct.
It's that form of rabies which spreads slowly, but both dumb and furious rabies result in death. We need to understand that.
Correct. I think this is a very important point Dr. Sanjay has brought, that when you have a patient who has got some encephalopathy, encephalitis, ascending paralysis, Guillain-Barré type syndrome, edema-like syndrome, and you don't find the etiology, you have done antibodies, everything comes negative. There is some history of bite in the past, especially not taking proper prophylaxis. You need to have rabies as a differential. And you can actually still prove it even then there are no other symptoms, either by doing CSF, sending the antibodies, or you can do the conjunctival swab or a neck of the neck biopsy and send for rabies virus. And all these tests are done at NIMHANS. Professor Anurag, you will want to elaborate? We have sent some and they've come positive. It's unfortunate that such patients, they don't even know that they had rabies. Have you sent any time such samples to
Yeah.
NIMHANS?
So what is now being developed is, which is being validated is rabies antibody titers in the CSF.
Correct.
So earlier it was not being done, it was not validated, but now it has been validated.
Correct.
So if the patient is unimmunized and has titers in the serum, it implies rabies. But if the
Correct.
patient is immunized
Hmm.
and then he develops encephalitis and you get titers in the CSF, that implies he has developed
Absolutely.
rabies. And other
Absolutely.
than that, yes, nape of the skin biopsy, you
Yeah.
can look for the virus.
Yeah. Negri bodies.
Conjunctival smears are not very sensitive. And
Correct.
postmortem Negri bodies are one of the ways. These are
Absolutely.
inclusion, cytoplasmic inclusion cysts, which
Yeah.
demonstrate the presence of the virus and are the pathognomonic of rabies. So
Correct.
these
In
are the
fact,
few tests which we
yeah.
have.
In fact, Dr. Anurag brought that point very rightly. Negri body in the brain. And in fact, USA is free of rabies, and they thought that animals don't have rabies. But very recently, there was a report that in a particular area of US, I don't remember, but there were cats which were not looked after by anyone. So they were not like pet cats, and there were 15 or 20. One of them were very furious. So they euthanized the animal, and they found Negri bodies. Then they caught another 2 or 3 cats which were in the same group, and they euthanized them, and again one more they found to have Negri. So it's not that you cannot relax as far as rabies prophylaxis is concerned, no matter which country you are. And I remember a report in the past where a billionaire was traveling and was in an area where rabies vaccine was not available. And he thought he'll go back home and take it after 4 days. And unfortunately, by the time he took and they completed, he developed rabies and died. I mean, a death because of rabies, which is so vaccine preventable, is, I think, completely not acceptable. All right, so that brings us that if you're going to vaccinate, and there are different types of post-exposure prophylaxis recommendation, Dr. Khadke, what are the categories? How you categorize any exposure?
So there are 3 categories of bite. One is basically first category is just feeding the animal, licking and intact skin.
Correct.
Because
or through a cloth.
Yes, and rabies viruses are supposed to transmit or with the intact mucosa also. So skin and licking, feeding really is a category 1, and where you really do not need anything as a post-exposure prophylaxis.
Correct.
In second is basically there is a transdermal bite or transdermal scratch, which has not seen any blood.
Correct. So
So
very
that
superficial scratch.
there is a superficial scratch and there is no blood.
Correct.
But the problem between the second category and third category is really marginal.
Very
So
good.
what you can do is a spirit test in those patients who have whether it is grade category 2 or category 3 bite. If you have a spirit and if you apply the spirit and if you feel that basically that is causing then that can be a grade 3.
So, Dr. Anurag, you may correct me. I do this way. There's an exposure where there is no scratch mark, nothing is seen. Patient says, I have bitten the elbow. I would put spirit there. If it burns, which means he had a scratch, that become category 2. If there's no burning, then you know surely there was no exposure and just forget about it. Moment I see a drop of blood, also it's become category 3.
The moment you see a drop of blood, it is category 3.
And 90% of the exposure are actually category 3. So I almost feel we should follow the American guideline that once there is exposure, just give local treatment as well, because don't break your head into category 2, category 3, because many times we have seen if you have misdiagnosed category 3 as category 2 and not give the local antibody, especially in a small baby, multiple wound near the sensitive areas like pulp or in the face, head, face, neck, it's asking for trouble if that was a rabies exposure. Would you want to add, Dr. Anurag, something?
Yeah, so I will make life very simple because everybody has to manage hundreds of diseases. So if spirit test is positive, it means that your integrity of skin is breached.
Correct.
You take it as category 3, don't fall into the story of 2, 3, and you give the immunoglobulin and the vaccine. See,
We'll
we
come
are
to that.
highly endemic country,
Correct.
and a lot of cases of rabies are seen after scratches which have been labeled category 2.
Correct.
So without taking any risk, any burning or tingling, take it as category 3, give immunoglobulin and the vaccine. Simple.
Okay, fine. Okay, before we jump to the vaccination and post-exposure, pre-exposure, etc., we many times forget the local wound care, which the parents have to be told before even they come to our institute for deciding what needs to be done. So, Dr. Anurag, how do you wash the local wounds?
So first of all, washing is extremely important, as said by you, sir. Washing removes 50 to 90% of the virus. There are two effects. One is mechanical, which means you, with the flush of water, you remove the virus. And second is the virus coat is lipophilic. So it dissolves by the application of soap. So the literature mentions carbolic soaps, but carbolic soaps are no more available in the country. We all have Syndex, but it is all right. They also dissolve lipid layer. Use it, wash it for 10 to 15 minutes in running water.
And 10 to 15 minutes go by clock, not by your patients.
Yeah, not by your patient. I know it is difficult because washing hands for 10 to 15 minutes, it is really difficult. So a problem comes when you're bitten on the leg. So you need a jet system or a pipe or something to wash your wounds on the lower limbs. Another problem is when you have bigger wounds that you cannot wash on your own with soap and water. You cannot apply soap on a flap of skin which has been removed. So for that, you require virucidals, simple, whatever is used in your OTs by dressers, but that has to be done meticulously with thorough irrigation with saline.
And I think you should expose the child or that adult and see there can be hidden wounds. Especially the child may not tell out of fear because he will think he'll get like more injections and you may miss a major wound, which is say on the buttock or somewhere which you are not exposed. All right. So Dr. Sanjay, lots of myths. What can be applied, what cannot be applied? Dr. Anurag said that best is soap and water, but something more can be applied and what should not be applied to the
I
local
think
wound?
I concur with Dr. Anurag that soap and water is most important. What is also important is virucidals.
Correct.
Virucidals,
Just give an example.
povidone iodine and alcohol 70%.
Okay.
Chlorhexidine is a bactericidal and should be avoided.
Correct.
If nothing is available, yes. No to any irritant, whether it is caustics, phenols, kerosene, petrol, chumna, chili, turmeric, herbal paste, topical antibiotics, virucidals are not virucidals. I was just wondering whether we can apply liquor which contains 70% of the wound. You can't because it's not sterile and the alcohol percentage is variable.
Correct. If you are in Gujarat, even that is not available. All right.
Hyderabad,
Doctor-
no problem, sir.
Okay. Dr. Khadke, I think very important. Surgeons want to suture the wound. We fight with them. They don't suture the wound. So what is the consensus? Which wound should be, if at all, loosely sutured, and when and how and under what precaution?
Irrespective of the amount of depth of the wound, we would differ from a suturing of the wound immediately. That is one.
Correct.
But if the hemostasis is a problem,
Correct.
and we want that hemostasis to occur,
Correct.
then prior to the suturing, probably we will give some monoclonal antibodies or
We must. We must.
first, and
Yes.
then suture, and that suture should be loose enough
Loose and only few just to arrest the bleeding.
just to arrest the bleed.
So when would you then actually suture the wound? If it's a little bad wound, when will you actually suture the wound? And secondly, suturing will be done when?
After 7 days, sir.
Okay.
After 7 days, because we are giving immunoglobulins as
Vaccines.
well as a vaccine, and
Correct.
immunoglobulins works for 7 days, and after 7 days the vaccine starts working.
Correct. Okay, fine. Anyone wants to add on suturing? Oh, that's perfect. Consensus? All right, Anurag. Need for tetanus toxoid containing vaccine, but there's another thing that is missed many times, and not necessarily all children are up to date.
Yeah, so that is the standard guidelines of road traffic accident, the ones we follow. If it is the child has received a TT containing vaccine within last 5 years, nothing needs to be done. If it is 5 to 10 years, then you have to give the vaccine. And if we are not sure that he has not received a tetanus containing vaccine, then you'll have to use immunoglobulin and the vaccine. That is simple.
Correct. And I think when you are giving the tetanus containing vaccine, give it age appropriate. Like suppose the child is 18 months and is not taken his first booster, give the first
Give
booster so
DPT,
that
yeah.
you don't have to again give tetanus, the booster again. And same for 4.5 or 5 years or a 10 years Tdap or TD vaccine, whichever you're giving. But after that, for the next 5 years, for non-contaminated wound, and up to 10 years for non-contaminated wound, the previous TT will work. All right. The last question before we jump to now the local therapy is use of antibiotics in a wound which is like large enough. Dr. Sanjay, would you give? If yes, which one and how long?
If indicated, antibiotics.
No, when would it be indicated? That's my question.
Multiple wounds,
Okay.
contaminated wounds, collateral injuries, crush injuries, yes.
Yes.
When you have a doubt of infection, yes, they don't interfere in any way.
Okay. And someone has not washed the wound and it's come a little late, maybe there's a chance that it was not washed, so maybe it's going to get infected. Which antibiotic would you use?
We would use any antibiotic which would work on the skin, amoxicillin, clavulic acid.
Or first generation cephalosporin, cefalexin, ciprofloxacin. All right. And how long you give? 5 to 7 days?
7 days.
All right. All right, now let's move to the most important and the most neglected part, and that's the local monoclonal antibody or the local immunoglobulin. Now, in past we had only immunoglobulins, but now we have an option of monoclonal antibody which almost are replacing the immunoglobulin. So, Dr. Khadke, what is the rationale of giving the local infiltration either of the immunoglobulin or the monoclonal antibody? Just to reiterate, we discussed it, but just to reiterate.
The 50% job is done with your local treatment. Washing the wound as well as the virus load would decrease 50 to 60%. And later on, we don't want this antigen load or virus load to be traveled through the peripheral nerves to the central nervous system and cause the disease. So we want to block it at the site of entry or site of bite.
Correct.
So that's the reason why we are supposed to give monoclonal antibodies or even human Rabies immunoglobulin at the site of bite.
Perfect. Dr. Anurag, if RIG or monoclonal antibody is not given on day 1, how long can you give when the patient comes late? So one, he has not started vaccine also, and other, he has started the vaccine on day 1, but now has come late.
So there are two scenarios. Number one is that he has not received the vaccine. So there is no upper limit as such. If he comes to you after 10 days and he has not received vaccine or immunoglobulin, you start the vaccine along with the immunoglobulin. So
along with the vaccine.
You cannot have, along with the vaccine. You cannot have an upper limit on this.
Correct.
Number two,
but suppose comes after 20 days, there is no wound seen. Where would you infiltrate?
Sir, I know it is a difficult question, but as a clinician, if he comes to you and you are making a prescription, you give it at the site where he claims that he was bitten and mention on the prescription that he has come to you after 20 days.
All right, fine.
The problem is that the virus, after entering the skin, can lie dormant at the site or can start multiplying and then later on bind to the nerve ending. So we do not know. Uh, if you look at it, less than 1% cases occur after 6 months. So
Correct.
till 6 months, maybe you can give. After that, maybe you can tell him that, look, now nothing can be done. The
All
second
right.
scenario is when the patient has received the vaccine. So
Hmm.
once he has received the vaccine, immunoglobulin can be given only up till 7 days.
Correct.
After that, the antibody production because of the
Correct.
immunoglobulin will take over.
Correct. So in the
Because of the
past,
vaccine will take over. Sorry.
right. So in the
Huh.
past, where we were giving immunoglobulin, there was also recommended to give half IM and half local. And when that was the case, it would interfere with the vaccine if you give it beyond 7 days. But now when you give it only local, nothing intramuscularly, even if you have exceeded 7 days, of course, it's not required, as Dr. Anurag said, because the antibodies have already started working from the previous 3 doses. But if you give it, maybe there will be no harm because there's no absorption of the antibody local when given locally. But still, 7 days cutoff is, I think, something which you should follow. All right, Dr. Sanjay, who should receive now? That's the question. All category 2 and 3 or only category 3 as WHO says?
I agree with Dr. Anurag and Dr. Nitin that categorization of category 2 and category 3 is splitting hairs actually. So all category 3 bites require an
For sure.
immunoglobulin. Yes, for sure. Category 2 and 3 as per the National Rabies Control Program would require antibodies, even category 2 also. Now, the previous vaccination status, if he is immunized but not documented, if he is immunized less than 2 doses would require. All exposure to wild animals may not be a bite, but all exposure to wild animals would require this thing. But the caveat what we need to understand is we don't delay giving the vaccine for the sake that immunoglobulin is not available. You give the vaccine. And I was just going through the WHO consensus statement. Proper wound care and PEP can prevent about 99% rabies.
Of course,
And
yes.
rabies immunoglobulin is given only in 2% of bites.
Perfect.
So let's understand the reality.
Okay. Dr. Khadke, where will you not give immunoglobulins or local therapy?
So for category 1, we don't require immunoglobulin.
Perfect. Category 2 as per
category
WHO
category 2 immunocompromised
should
will
give.
require, but immunocompetent will not require.
Okay. And
And
re-exposure?
those who have already received pre-exposure prophylaxis will not require.
Correct. But if he's immunocompromised and has received pre-exposure, he would still require.
Then still he will require.
Because you may not depend on his recall memory or the antibody
Yes, sir.
status.
Yes,
Okay,
sir.
I think this is an important thing. Just to reiterate again, this is important. Most of us feel that categorization is little difficult. When in doubt, give. Category 3, 100% give. You see a drop of blood, give. Re-exposure, no need to give unless immunocompromised. Someone had anaphylaxis in the past with a immunoglobulin product, maybe you should not give or try to desensitize. Dr. Anurag, have you had any case where someone was sensitive? Of course, we don't do any testing anymore, but when we were using the equine, that was a problem.
Yeah, so earlier, till 15 years ago, the product was not very purified. So we used to have a good number of reactions. I'm
Correct.
talking about equine.
Yeah,
So, after 15 years ago, what they started doing was breaking up the antibody into FC and FAB portions. And
Correct.
they were giving us one portion which is required, which is protective, and the other portion was causing reactions. So
Correct.
now the reactions have decreased to such an extent that maybe other than vasovagal syncope and little bit of pain or fever, we do not see anaphylaxis. We do not see the need for admission of any person who has received immunoglobulin. It is that safe. I'm talking
Okay.
about equine immunoglobulin.
Correct.
Monoclonals, we have done multiple trials and studies, and there is hardly any reaction other than, again, some bit of pain and all that. Same with H-ring.
So, Dr. Anurag, you have, when you have treated, I think, thousands of patients in your centers, and of course, because you are leading the consortium, you would have experience from others. What is, I mean, maybe not only children, adults, immunocompromised, and then the question comes whether vaccine will work, whether antibodies will work, both will work. What's your
So,
status?
what we did was in our recent publication, we took 10 children who were immunocompromised. That is, they were on treatment for juvenile inflammatory arthritis, JIA.
Okay.
We were giving them methotrexate long term, and there were four patients who were on steroid-dependent nephrotic syndrome. So they were on steroids or TAC.
High dose steroid.
Yes, high dose or tacrolimus.
Okay.
So we compared them with healthy children. What we got was that after 2 doses of vaccine, so it was a pre-exposure prophylaxis study, they developed good titers at day 28, but the fall in titers in these children was pretty rapid.
Correct.
So this simply seems that you need to give them a complete treatment, that is immunoglobulin and the vaccine,
every day.
Ideally get titers done, or but basically if you have the facility of getting titers, get titers done at day 14 and day 28, or give them an extra dose at day 90. These are the two options available to you in immunocompromised children.
So that 0, 3, 7, 14, 28, and 90. That 90 has been dropped except for immunocompromised, where there's an option.
So
okay,
better
Dr.
is better is you do titers. We have titers available in our country. Some
How much does
labs
it cost?
We do it.
How much does it cost?
Around 4,000 rupees is the cost. And we at NCDC it is free, and MAMC we do it for research purposes. So we do it en masse. We get a kit and we do it for our thesis and projects.
Dr. Sanjay, the commonest issue is how do I infiltrate? Because pediatricians are not surgeons, they are not infiltrating the wound for the local anesthetic, and they don't know how to do it. Can you just explain?
Number 1, don't touch the wound with bare hands. Wear a glove.
Correct. Okay.
Number 2, wash and apply virucidal. Let the virucidal dry.
Perfect.
Number 3, warm the immunoglobulin. You don't infiltrate the cold immunoglobulin. Number 4, use a needle and a syringe.
Correct.
Number 5, remember the rule around and into. Plain is not important. It's not important that you give subcutaneous or intradermal or intramuscular. It's the depth of the wound which determines.
So the edges and the base.
In and around.
In and around. And how we know you have gone enough? Dr. Anurag used to always say that some fluid should ooze out from the wound, from the base. Then you know
the tissues should turn turgid and some fluid should ooze out.
Okay, I think this is very important. If you are not sure how to give, please don't give and mess up. Just refer to a center where the people know how to give it. All right, doctor.
Or message me. I'll send you the video of infiltration.
Oh, please send it. We can circulate it in our MyIP group. Please do it. Definitely. All right, Dr. Khadke. Now the question: there are two small wound, and my calculation is saying I have to give 1 ml, but I can't infiltrate in such a small, just a puncture mark. Or there are multiple large wounds. How do I go about?
So first scenario is we have a small wound.
Yes.
So in small wound, we just have to see to it that maximum dose of immunoglobulin we should be able to infiltrate in the edges as well as base, but it should not cause a compartment syndrome.
Correct. So if you need less than what you have calculated for a small wound, don't try to give everything. It's okay. Just give as much as required.
We don't want to have compartment syndrome in a small wound. So we will have to discard it or use it for other child.
Correct. Now too many wounds, too large or too many large
wound, we can dilute it in normal saline and give it to all.
So how many times can you dilute?
Dose doesn't increase. Dose will be same. But at the same time, you can dilute it to twice, thrice, 5 times and give it at multiple places.
Correct. So remember, do not exceed the calculated dose in whatever units per kg. Dilute to cover every wound, and don't forget to cover even the smallest wound where there are multiple wounds, because that can be the reason for rabies and you will have trouble. Dr. Anurag, there was a question put, and I think I see Sagar was here and he had put in our group that someone had some 20-30 wounds and he said, I have diluted 100 times. Can I do it?
Yes.
So that's
you use equine rabies immunoglobulin because dilution has mainly been studied on equine.
Correct.
Yes, monoclonal we did dilute for a few patients in our study which was going on, but equine is 300 IU per ml. So you can dilute it easily for much larger quantities as compared to monoclonals, which are 600 IU per ml, the twin wrap preparation I'm talking about.
Correct. Okay.
So
we have two types of local therapy. First is immunoglobulin. They are less and less used, but we will discuss it nonetheless. So Dr. Anurag, what immunoglobulin preparation are still available in our country? Equine, human,
and monoclonals.
And mono. So monoclonal we will discuss later. Only immunoglobulins.
Okay, so we have human and equine available.
Okay.
Equine is produced in our country. Yes. So equine is produced in our country in good amount. There are 2 or 3 major manufacturers and 3 or 4 suppliers in the market. The dose is 40 IU per kg, which is the maximum dose you can give, 40 IU per kg, and there is no upper limit. So it will be multiplied by weight. If it is 100 kg, 40 into 100, 4000 IU.
Correct. And
Now
this
coming-
available as strength wise?
Strength wise is 300 IU per ml. It is available. And human is available as 150 IU per ml. It is imported. Initially, it was coming in good amount from Israel. Now Israel does not have the capacity to supply to India. So now we are getting small quantities from China.
Correct.
And it is pretty costly, and usually most of our patients will not be able to afford
And
it.
the dose is less, 20 units
20 IU per kg.
per kg. And
Yes.
cost is humongous.
Cost is for a 70 kg person, it will cost you around 25,000 rupees.
Oh, that's beyond. Okay. So Dr. Sanjay, any pros and cons when you use either the HRIG or the ERIG besides the dose that Dr. Anurag
I think
mentioned?
Anurag has covered everything. The human rabies immunoglobulin is from human plasma, and the equine rabies immunoglobulin is from the horse serum. But one thing we need to...
Should you give a test dose when you use equine?
No,
No
no,
need.
it's not required. We have already covered it because it's a purified equine rabies immunoglobulin, which contains the FAB2. The FAB part of the antibody is there. The FC is removed. So
But in
serum
any
sickness
case,
is
be
not a problem.
prepared. Anyways, be prepared for anaphylaxis following any vaccine.
Yeah,
Forget
1
about
in
only
1,50,000 is the reported. But there is one feedback I would like to give, Nitin, is that do not wait for a specific product. Whatever is available, please give. Time is the critical window.
Dr. Khadke, now that we are not getting too much of ERIG or HRIG, we are using more and more monoclonal antibodies which are easily available. So please tell us what are the 2 different brands and whether they cover all strains of rabies.
See, we have monoclonal antibodies, which is rabies shield.
You can take the names here because there's no problem at all. Yes.
It is from a human source. And second is basically twin rab, which is from a murine source. So this twin rab basically acts on a 2 epitopes, while this monoshield rabies shield acts on a single epitope.
But does it really matter? I mean, both have been studied and found to be effective.
Basically, it is been said that rabies, like viruses, can be neutralized by 2 epitopes to be applied. So whether they make any significant difference in protection in India is for ACUIP, and everybody says that they both are same. The doses are different. 3.3 unit for monoclonal rabies shield and 40 units per kg for the twin rab.
Twin rab, okay. And do they cover all these strains?
25 stray dogs are
tested
in this rabies shield.
Okay. Is there any strain which is missing, which is not covered, Dr. Anurag? I think that's the one which is found in bats, but that's anyway not a problem in India.
It is found in bats in Peru, which is not covered by rabies shield. But in India, it is not a problem. Everything is covered, and the antigenic site is highly preserved. It does not mutate. So both are good as far as we practitioners are concerned.
Okay, so Anurag, now the availability of these 2, the strengths in volume and the cost.
So
let's talk of Rabies Shield first, Serum Institute.
Rabies Shield dose is 3.33 IU, as sir said rightly, and 2.5 ml vials are available containing 100 IU.
Correct. So say a 30 kilo child would need 100, and
that
will be 2.5 ml.
Yes.
And if there's a single small wound, you may need only 0.5 ml. Don't worry. Don't try to inject entire thing there.
Yeah, don't try to inject entire.
And multiple large wounds, you may need 5 ml diluted 1:1. Correct?
Yes.
All right. Now the other one, and what's the cost? 2.5 ml
cost is around 2,000 rupees to the patient and 1,400 rupees to the doctor, approximately. This is
okay, fine. And the twin rab?
Twin rab is available at 600 IU per ml. And 2.5 ml vial will contain 1,500 IU. Correct. And dose is 40 IU per kg.
So per dose cost wise, which is more? Is Rabies Shield cheaper or?
There is a slight difference in cost between twin rab and Rabies Shield. Twin rab contains 2 antibodies. It's slightly costlier. So around 2,500 rupees approximately.
Okay, fine. So I think this is important. First dose is 3.3 versus 40. Second, the volume you decide based on the body weight. Third, you decide how much you need to give in the wound. If it is too much volume, do not worry, don't have to push everything. If it is too many wounds, don't worry, keep on diluting. First decide before you inject the first wound, because you may run out of it after covering 3 wounds and now you can't exceed the dose. So first decide how many ml you're going to need in the number of wounds. Accordingly, dilute it and try to give it. Is that correct, Dr. Anurag?
Yes, sir. So we did a study around 2-3 years ago, wherein how much can be infiltrated approximately. So we found 0.75 ml per centimeter for linear wounds. So if you have a wound which is 3 centimeter long in soft tissue, you can infiltrate around 0.75 into 3. That comes to 2.25 ml approximately. So you can have that approximate volume, and if it is less, as per the body weight, dilute with normal saline and infiltrate.
And so the last question before we move to the vaccination, Dr. Sanjay, your choice, if both are available, would you use the Rabies immunoglobulin or the monoclonal antibody?
Yeah, let me again
And why?
reiterate.
Yeah.
Let me again reiterate that give whatever is available. The speed is
No,
important,
both are
not the
available.
choice.
Both are available.
Speed is important, not the choice. If
No,
both are
available in your
my
fridge.
choice as a private practitioner would be to give monoclonal antibodies because they are easily available. They are cost effective when compared to HRIG. They are safe and synthetic.
Absolutely.
They can be produced in large amounts.
Correct. So I think they are cheaper and easily available. Immunoglobulins are difficult to make because human volunteers are not existing, and equine people are worried that they may actually lead to some reaction. All right. Anything else you want to add, Dr. Sanjay?
Yeah, just about, because rabies is such a topic, the schedules, the immunoglobulins, the debate is so long, and there are so many contrary points about it. The NRCP, I wanted Anurag's opinion on this. The NRCP says in its guidelines 2019 says that monoclonal antibodies in the Indian scenario needs further studies. Your take, Anurag.
So, sir, I am a part of that expert committee. And the problem is that they were not very happy, the people from Nirman. I'm giving you the inside news. And they said, let us have more data on it. And after that, more data has been created. We have just recently published in Lancet a data of 4,000 patients, and wherein no patient has died after 1 year. And it is felt that in dog bites, 1 out of 69 dog bites are considered to be a rabbit bite. So if you do 4,000 patients, you can see around 500 to 600 patients must be from rabbit dog bites. Similarly, the other pharmaceutical, that is Rabies, Twin Rab, it conducted a study on 1,500 patients. Again, we were a part of it, and nobody developed rabies. Everybody was alive after 1 year. So that data has been submitted to NRCP, and we again had an expert group meeting around 6 months ago. And we told them that, look, the data is there. Now we have to modify the guidelines and accept it. So there is some dilly-dallying going on from government side, basically the committee side, but WHO has accepted it. In fact, WinRab was made on WHO recommendations because you cannot have sufficient amount of equine or human rabies immunoglobulin. We are only covering 5% of the bites as per the latest Lancet publication 2024. So if you want to cover the remaining, you have to have a supply which is unlimited. And that is only possible with monoclonal antibodies.
Correct. So
we
I can
have to move
reiterate
towards it.
that WHO says to use monoclonal antibody preferentially. ACYPS said to use monoclonal antibody. Members should use monoclonal antibody more often than trying to break the head to get the immunoglobulin. I think that we'll move to vaccination, and maybe vaccination everyone knows, but some points we can discuss. Dr. Khadke, what rabies vaccines are available for human use, and is there a choice between pure chick embryo versus Virorab?
Sir, we have pure chick embryo
You can take
vaccine.
names of some brand because people let them be aware.
Rabipur is basically a pure chick embryo,
PCV,
and we have
okay.
Verorab, which is available as Verocell vaccine.
But that's no more available, isn't it?
No, not available. Both are not available.
So we have the Rabivax S, which is again a Virocell, and you have
Virocell.
Abairab, which is again Virocell, right?
Abairab is also there, sir.
Yeah.
So there is one brand which is PCEC, and I think it is Chirorab. I'm not very sure, but
that is now been made
clinicians,
available. So what was Rabipur is now Chirorab.
Chirorab. So as clinicians, we are not bothered about PVRV or PCEC. For us, all are same.
Correct. So that is the bottom line. Use any vaccine which is licensed in our country, and there are 3 or 4 brands. And in fact, there was one brand, Zuvirab from Juventus, but now that's not available because the source which was in China has stopped manufacturing. Okay, let's come to Dr. Anurag. Intramuscular versus intradermal route, and precaution while giving intramuscular route, and who can use ID route. I think this is important. So first, intramuscular versus intradermal. What is your choice?
So in government setups, we are using exclusively ID route over last now 15 years. And when I
That's for
started
cost
using
saving,
ID,
right?
yes. So when I
Yeah, but
started
if
ID, I sent 100 samples to MCDC. I was also very afraid, and we got 100% seroconversion.
perfect,
And after that, I have done multiple studies. Around 5 or 6 have been published, and we have got very good seroconversion.
perfect. But
Now
in your
coming to private
practice,
sector. Private sector. Private sector, because you get maybe one patient a week, you can continue with the IM schedule because there is some bit of lack of confidence in giving intradermal in the private sector. Although we are all pediatricians, I don't think it is a big, huge technique issue.
So I always say that if you have given enough Mantoux tests as a resident, then probably you know how to give intradermal. Otherwise, don't venture into it.
Or BCG, sir?
BCG, BCG nowadays, very few people give in private. Okay, go ahead. Who can use ID route? Can pediatrician use? Suppose he has a center where 4, 5, or suppose hospital, like Rainbow has 4, 5 patients coming every day.
Definitely, sir.
So there is no embargo on using. Initially, it was not licensed, right?
Yeah, you can use ID if it is so the vial writes IM oblique ID route. Nowhere it says that ID route is to be used only in government. That is the mindset which we have developed over the years because government has a high load. We get around 15 to 20 fresh cases and 40 to 50 follow-ups. So we use ID route. If you get a family with 2 or 3 kids bitten, you can use ID route. It is cost saving for the family.
Perfect. Sanjay, IM post-exposure schedule and 4 versus 5.
Yeah, the schedule, we have 2 schedules. One is the 5-dose protocol, which is called as the SN protocol, 0, 3, 7, 14 to 18, and then 90 days. Then we have the shortened SN protocol, which is 0, 3, 7, 14 to 28 days. Now, if you look at the first protocol is recommended by the National Rabies Control Program, and I want Anurag to give insight in.
No, but that I think they need to change because WHO says, ACPP says, CDC says they are a little late in. Have they changed, Anurag?
I'll give you an answer to this. In the last meeting around 1 year back, I fought with them that why do you have 5 doses? Remove 1 dose. They said, who gives IM? They said, we are giving ID. Nobody gives IM. I told them all the private sector is giving IM. क्या डॉक्टर साहब छोड़ो उनको, हमें ID लगाना, ID में हमारी 4 डोज है, IM से ज्यादा परेशान होने की जरूरत नहीं है.
No, then why are they recommending IM schedule at all if they are not using it? Then they should leave it to the manufacturer.
It is just the part of the module guideline which is coming. So this was the discussion which took place. I'm telling you the true story inside. And now the problem is that we as pediatricians from India, what do? So we feel that because of the medical legal issues and all that, it is better to follow the NCDC 5-dose schedule 0, 3, 7, 14 and 28.
But ACPP says 4 doses. So you have umbrella. All right. All right. So Sanjay, the 4th dose on day 14 or day 28 or anywhere in between?
Anywhere in between 14, 28.
Earlier the better, no? Patient may forget to come back. Okay, fine. All right, Dr. Khadke, can you use 2 doses intramuscular on day 1? I mean, there was some schedule in the past. Even it's mentioned in the WHO position paper. What is the reason behind?
Sir, probably we are talking about Jagre protocol.
Yes.
Where we didn't have access to the monoclonal antibodies or human immunoglobulin, where we want to increase the antigen load so that basically
on day 1 itself.
So that basically the viruses are blocked there only.
Okay. So, but we don't generally follow that rule. Unless someone comes late, Dr. Anurag, day 3 and is not taken. He's very worried. Can you use this?
No, sir. We don't recommend it in India anymore because we have supply of monoclonals and everything available.
Absolutely. So, Dr. Anurag, now that you practice mainly in MMC and you are one of the government centers, tell about the ID route, post-exposure schedule, and again 3 versus 4 doses.
Yeah. So we are using the 4-dose schedule 0, 3, 7 and day 28 in ID route.
Correct.
Now,
and on each day, how many sites?
So it is 2 site ID. Both shoulders, 0.1 ml. Yeah, 22202. 0.1 ml on both the shoulders, 0, 3, 7 and 28. So day 14 we did not give it, so 22202.
Correct.
Now coming to the 3-dose schedule, which has been approved by WHO, that is a 1-week schedule 037. So
Correct.
what we did was, my paper is accepted in ESPID Society, that is Pediatric Infectious Disease Society Journal. It will be published in another month, wherein we studied the 3-dose schedule. That is the IPC, Institute Pasteur de Cambodge study.
So
I'll
you
not
did
discuss it,
the
it's a long
you did
story.
the antibody titers on day 14.
Yes.
Okay.
On day
And what was the
28.
on day 28?
Day 28.
No, why not day
037?
14? Because there's you're worried about what happened on day 14.
So, yeah, so day 14, but we want the persistence of titers also.
But that
was
wouldn't
our aim.
matter, because if someone is covered today and doesn't do rabies, if he's going to be re-exposed anyway, he's going to take 2 more doses.
So the schedule was 037 and 28. So we were thinking of why to give day 28 if the person has titers on day 28 itself.
Correct.
So that is the reason we took day 28 as the cutoff instead of 14.
But did you also study day 14 in that?
No, in that study
to
we did
compare
not
with
study.
037?
No, we studied at day 28. So what we got
Perfect.
was 90% patients seroconverted, the 10% did not. So 3 patients of ours did not seroconvert at day 28. You understand? Now we gave them booster of day 28 and we did the titers again. And out of those 3, 2 seroconverted, and all the 3 patients we worked up for immunodeficiency extensively. We did not find any evidence of immunodeficiency in these 2 children. So now comes the question.
Can I conclude to say that that's because the intradermal route was not given perfectly?
Yes. So that is what I'm trying to say, sir.
Correct.
So we feel that in a country like India, wherein an institute like Maulana Azad, wherein we are giving around 70 to 100 patients a day, we are having this problem. The vaccine, although it is very hardy, there can be some amount of cold storage issues also. So a tropical country like India, it is always better to give an extra dose than to have a problem of rabies in patient receiving 3 doses. So our recommendation is it's good to have 4 doses, that is 037 and day 28.
So is the government going to change to 3 doses for intradermal route based on the WHO recommendation?
There is another study going on in South India, and NIV Pune is doing the titers. And we will wait for their results, and our study will be published soon, because ours is done exclusively on children and they are doing it mainly on adults.
All right.
So till date, we are following the 4-dose schedule.
Okay. So Dr. Sanjay, we discussed this before, but till what time is previous post-exposure valid for re-exposure? 1 month, 2 months, 3 months, 6 months, 1 year?
Yeah, number one, we need to document whether it was proper post-exposure prophylaxis given. Because let me reiterate the statement which we made in the beginning, that it is necessary to prevent rabies because it's potentially vaccine preventable and it is invariably fatal. The 3 months, if you have received the post-exposure prophylaxis within the 3 months, there is no need to give the immunoglobulin or the vaccine. But if it is beyond 3 months, then you need to give the vaccine, not the immunoglobulin.
So my question to Dr. Anurag, now that you did the intradermal route on day 28 and you found that 2 of the 3 were not seroconverted, let's say forget intradermal route. Has anyone done comparison of 4 versus 5 dose, how long the antibodies remain? Because that's a bearing. Like when you give 037 14, okay, you have prevented rabies, but suppose in next 2 months the titer may fall below 0.5.
Yes. So multiple studies have been done, and in pre-exposure and post-exposure, follow-ups have been done for years together. We have around 25-year data. It was
I'm saying the first 3 months. Is it sacrosanct?
Yes. 3 months, the titers are there in nearly 100% of the patients.
Irrespective whether it is 4 dose or 5 dose post-exposure prophylaxis.
Yes.
All right. So that is very reassuring. All right. So I think now we move to the pre-exposure. Dr. Khade, what is the rationale of pre-exposure prophylaxis?
See, the pre-exposure prophylaxis would have 2 benefits. One benefit is basically you would require lesser doses of vaccine later on. At the same time, you will not require any monoclonal antibodies or human release immunoglobulin.
So you are priming the immune system for future exposures.
Yes, sir.
Correct. All right. What is the schedule, Dr. Anurag, for pre-exposure for both intramuscular and intradermal route?
So presently, what is approved by Government of India, that is NCDC, is 0721/28. So 3 doses are approved.
So again, that's a dispute.
1 ml. Yeah. No, sir. 21 or 28. If you want it early,
it's 2 doses by WHO
versus
and
3 doses. Yeah. So I'm coming to that.
Okay.
So it is 0.1 ml, one site. Okay. And IM you give full dose. whatever is
Correct.
the vial, half ml or
Correct.
1 ml.
Correct.
Now coming to WHO and ACVIP,
Mhm.
WHO says that 2-dose schedule 07 is also sufficient. It
Correct.
is 0.1 ml at 2 sites.
Two
So you are
sides.
giving
Correct.
larger amount of antigen, more
Correct.
antigenic spread. So
Correct.
we just published a study in the journal Infection, which is again an international publication. Around 1.5 months ago, I posted in some of the groups also. We did in children 0 and 7. One group was again immunocompetent, another group was immunocompromised. And we got excellent results in these. The only
Correct.
caveat is that 3-month window period does not apply in these patients
Correct.
because they have received just 2 doses and we got the same results. Some
Correct.
patients became seronegative at day 90. And as soon as they were given boosters, they again became, the titers were reaching protective levels.
So you mean to say the re-exposure, any past prophylaxis given for re-exposure, 3 months duration is valid only for if it's given intramuscular. And for
So-
intradermal, 2 doses, it's not valid.
2 doses, it is not valid.
Correct.
3 doses, you can follow. And of course, post-exposure, it is valid.
All right, Dr. Sanjay, who all should receive pre-exposure prophylaxis?
Yes, it should be given to all those people who have a high rate of exposure,
Like,
people who work in the lab with the rabies virus,
okay,
people who have frequent exposures, like who have dog breeders, animal handlers,
correct,
people who travel to remote areas and who live in outdoor environment,
correct.
those exposed to wild animals, not given, but I would like Anurag's take on pets, children who have pets at home.
Why only children? Anyone, adults, so anyone who has
Yeah,
pets at
adults
home.
and children, because we
Correct.
see children, I was talking. Now, the point is whether routine pre-exposure prophylaxis is cost effective for children, because that's one we need to debate. And the WHO paper says that the cost is 100 times more, because the cost for post-exposure prophylaxis and mass vaccination of dogs, 70% is recommended. The cost would be $63, whereas if you give routine pre-exposure prophylaxis to all individuals, the cost would hike up to 3,500. So
But
60 times more.
that's for public health. I mean, for
Yes.
individual use, I would strongly recommend anyone who has pets at home,
Yeah,
anyone morning jogger, walker, milkman, postman,
I
anyone
do
who's
that.
laboratory worker, or children staying in slums where they have community pets which are exposed because they are small and they are all the time. These IAP also is saying the same, that these high risk population, which include children in the slums, should actually be offered pre-exposure prophylaxis. The reason is because many of them cannot afford the monoclonal antibody if they are bitten. Dr. Anurag, any want to add anything?
I say I totally agree with you, sir. In fact, most of us should take pre-exposure prophylaxis because we are surrounded by dogs.
Correct.
As soon as you go down in the society, you'll find 7 to 8 dogs around you. So,
Yeah.
yes, sir is right that dog vaccination should be prioritized. But
Mhm.
till dogs are vaccinated, we have to take care of ourselves.
Correct. Now I'm going to run as the last part some 8 or 10 clinical scenarios, and I think that's the most confusion when there is a delay, schedule, something has happened. Let's start them as a sort of rapid fire. Dr. Khadke, does the bite following animals need rabies? Squirrel,
No,
domestic rat,
no,
rabbit,
no,
cockroach?
no.
Now, squirrel, Dr. Anurag, South, there were some cases
Yes.
of squirrel having rabies. What would
So,
you do actually? I mean, you can't tell the
so
patient, see, South mein hota hai, idhar nahi hota hai. You can't
So
say like that.
there is a problem. There is one case report published in IP or IJP, I don't remember,
Correct.
but there is an association between squirrel bite and rabies. That's just one case report.
But there
So
could have
what
been
we
also exposure to some cat or dog, which is
yes. So we are just saying it's an association, not
correct,
a sure shot thing. 15-20 dead squirrel samples in South India were found to contain rabies virus. Having said that, no other case has been reported. So when
Exactly.
we say that if a squirrel comes and bites you, maybe you take the complete treatment. If you are putting your finger in squirrel's mouth trying to feed it a nut and it nicks you accidentally, then it
Then
is
it's
your
okay.
fault. I don't
Perfect.
think it will cause
Perfect.
rabies.
What about birds? Never.
Never. The
Okay.
body temperatures are different. Virus does not
Yes.
survive
What
at
about
that
bats?
temperature.
Bats in India.
So fruit bats, there again same dead bats in Nagaland and certain areas northeast were found to contain the virus, but no transmission has been reported. So till
Correct.
date we are following the guideline. In India, bats no. In
Correct.
America, bats, yes.
Yes, and in America, bats, even when you have inhaled while
Yes.
traveling to the caves, is enough to
Bat
lead to
caves.
exposure. Right. So
Yes.
you should be careful when you go there. All right, Dr. Sanjay, what if the rabies vaccine is given in gluteal region? One dose or all the doses?
If the vaccine is given in the gluteal region, then it is invalid.
Invalid. Even
Because
if they have taken 3 doses, they are all invalid.
they are all invalid
Or
because
can you do a antibody titer, like say Dr. Anurag?
ideally, yes, if I was in Anurag's place in Maulana Azad, then in Hyderabad, no.
No, the question is the parents say, okay, doctor gave 3 doses, but I can afford 4,000 rupees. If you can do the titer, and if they are okay, then I don't want to subject to another 4 doses. Dr. Anurag, that's fair argument?
I totally agree, sir.
All right. Okay. Dr. Khadke, for small wounds, can we give remaining dose of monoclonal antibody intramuscularly? I don't want to waste it.
No, sir. No, sir. If at
Okay.
all you have some other patient coming in the on the same day, then you can give that to the other child.
Otherwise, don't just waste it. All right, Anurag. What about mucosal exposure? Where do you give your monoclonal antibody? Suppose someone, the cat has licked the mouth of the child while kissing, or on the, like say, slapped on the eye and there was a redness of the conjunctiva.
Yeah, so conjunctiva, you dilute it 1:1, make it an eye drop and instill in the eye, and of course irrigate the eye. Oral
Correct. So
mucosa,
there you keep on irrigating because the drop doesn't remain. So you can actually use the
Yes.
full volume and just keep on doing.
And irrigating.
Right.
Yes.
Okay.
Oral
And the
mucosa,
saliva, yeah.
Yeah, oral mucosa, you can use an insulin syringe to infiltrate if you find any nick anywhere. Otherwise, you can ask the child to gargle with dilution of 2 to 3 times. He can gargle and
Correct.
for 10, 12, 15 minutes and spit it out. That
Correct.
is,
And
if
suppose
you
small
swallows
child
it is not a
swallows it,
problem.
child
No
small
problem,
swallows it,
sir.
no problem.
Nothing,
Right.
no problem.
All right. So I think that's an important message because there's always a confusion. And I don't know why pediatricians don't want to discuss rabies, a common cat, dog, something biting. Some child drank milk and then he came and then a cow came and all sorts of things which are there in the group just to confuse. But I think very right. Because if you can see a wound, try to infiltrate, otherwise rinse in mouth and instill in the conjunctiva. All right, Dr. Sanjay. Post exposure is delayed. How long can you still start?
Let's start as early as possible. But
And
if
then,
you have
no, so
delayed,
6
if you
months,
have
1 year.
delayed, if you have delayed, then you can start it whatever be the age.
No, so weeks, months, years. What, like 5 years before I had a dog bite? Would I
As
take it now?
long as the patient is asymptomatic, you can start.
So,
This is
Dr.
what
Anurag, you had said something that beyond 6 months is almost unknown, right?
Yeah. So that
So,
is
but
less than 1%. So
yeah,
before 6 months, if he comes to you, you can give it, mention on the prescription.
very fine. All right, Dr. Anurag, monoclonal antibody or RIG is not available with the first dose. Now, what do I do?
You give the vaccine, and as soon as it is available, it happens many times. I get calls from interior Madhya Pradesh. I remember a police person, commissioner was bitten, and the monoclonal was not available in Khandwa or some place was there. It was sent from Indore. So it reached by the evening, and it was given after 8 hours. So you have to do that only, no
Correct.
doubling of doses and
Yeah,
all
and
that.
I think you, as you said, cutoff is 7 days. Up to 7 days, you
Yeah.
can still give it,
Up to
but
7
after
days.
that, the vaccine would take over. So there's no need.
Yes.
It's a waste of resources.
Huh.
All right, Dr. Sanjay, a child has drunk milk of a suspected rabid cow. Is there a real exposure, and what do you do?
the answer is no. But the caveat is avoid drinking milk from a rabid cow. Number one.
No.
Number two, try to find out what sort of milk was it. Was it pasteurized? Because pasteurization kills the rabies virus. But
Correct.
if he has accidentally drunk milk from a rabid cow, rabies is not transmitted. But if there is any iota of doubt that he is in contact with the secretions of the cow, the oral, the salivary secretions, then please give the post-exposure.
Just boil the milk, and that's the end of it. Whether the cow was rabid or not doesn't matter. All right, Dr. Khadke, a child has kissed the cat which dies after 5 days.
Now here the scenario is basically we really do not know whether the cat was rabid or something, but we
Correct.
can't
So
take
you always
risk.
presume it was
So
rabid.
we presume that basically it was rabies. So we will give immunoglobulin as well as vaccine. But at the same time, where to give immunoglobulin? It is
So
all
that we discuss for
rinsing
oral mucosa rinse,
oral
make the child
mucosa. We have to
rinse.
rinse the immunoglobulins and give vaccine.
Suppose the same cat dies after 20 days.
See, the rabid animal is supposed to die in first 10 days of
Correct.
symptomatic rabies. So
Correct.
if the cat dies after 20 days, probably it may not be rabies.
No, even if it is rabies, the animal was not infective on day 1 when the
So-
child kissed that.
So this rule
Anurag,
is
that's fair?
so this rule is applicable only for dogs and cats, not other
Correct.
animals.
Perfect.
Yeah, correct.
They can act as reservoirs.
All right. Anurag, to you, a child has taken first dose ID at public health, now wants to come to me and take intramuscular. Can I
Yes.
first of all continue ID? You said yes.
Yes.
Can I switch to IM?
Yes.
So, yeah, I mean, do I
Count
calculate
the
the first
first
ID?
dose. No. Count the first dose. First
Count the
dose
first
ID
dose.
is there. Second
Correct.
dose you give IM, and then you
Correct.
follow the IM schedule.
Schedule. So, like the ID is given on day 1, patient comes on day 3, I give IM, then I give day 7 and day 14 to 28.
Yes.
Perfect.
Day 14 and day 28.
Correct. No, but we are giving only 4 doses. So,
All right, sir. Both will acceptable.
Okay, and same thing. Suppose someone has started intramuscular with my place. The patient say, I can't afford your chat, doctor. I want to go to public health. Can you switch to ID route?
Yes.
And again, the first IM dose I have given is valid.
Is valid, definitely.
And then you will give only the remaining 3 intradermal routes at day
Yes.
3, day 7, and day 20.
It's a common scenario with us.
Perfect. I think there is beautiful study done by Dr. Madhusudan's group where they actually compared transfer of route from intramuscular intradermal and vice versa, and they compared the antibody titers on day 14, which is the most critical, and how many of them are more than 0.5. They found that whether they received all IM or all ID or ID followed by IM or IM followed by ID, there was absolutely no difference, 100% seroconversion. So I think that's a great thing that you can do, and you can switch, no problem. All right, Dr. Sanjay, by the same breath, someone has taken a cheek embryo vaccine and now you have only Virora vaccine, or vice versa. Is there any difference in the brands?
If one
Not
brand
brands,
is
but
not-
the source.
If one brand is not available, then the schedule should not be postponed. It can be substituted with another brand, but you need to document it. But ideally, it's better to use the same brand.
Perfect. I think again, same Dr. Madhusudan's group did a study in pre-exposure where the children, people who had received chick embryo vaccine now were given the Virora and vice versa, and they found again that the
There is no
14-day seroconversion the same. All right, almost the last question. What about the unique 3-dose vaccine for adult Rabies, Dr. Anurag?
So this was launched 2 or 3 years ago. The problem is that they have just one study in which they gave the vaccine IM and immunoglobulin was not administered. It was given to healthy volunteers. They had their titers done and they published and they were given approval. Our problem is, number one, it is no data on below 18 years.
Correct.
Number two, there is no data on interference with immunoglobulin.
Correct.
So, as it is, our population is not covered. Even adults, I will be wary of using this product till they have more data. It is
But
good
it's
or bad, I do
licensed.
not know.
But it is licensed in our
It
country.
is licensed, good or bad, I do not know. I cannot commit on that. So I have asked them to produce more data, do 2 or 3 more studies, do it in patients who have suffered dog bites, collect data, see interference, look at the ID route. Only then maybe we'll be able to talk about it.
So it's a recombinant vaccine, right?
Yes, the protein, it is nearly the same, some difference in the technology by which they have produced it.
Recombinant
No, what I mean is like the other
Nitin,
vaccines
before
are...
you throw open the question,
No,
can I
I'm
ask
not.
it?
No, wait. Before, the other vaccines are killed vaccine, which means they are wholesale vaccines. This is a recombinant vaccine.
Yes.
Probably that makes it more immune. Like we know, varicella vaccine,
So
zoster vaccine.
WHO says 037 is sufficient.
Correct.
So it is the same story. You can shift to Himachal Pradesh. They are giving only 037. They have taken out an order from state government. And
for all the vaccines.
Yes. For all post-exposure, they are giving 037. So
and no day 14.
No day 14 and the 4th dose is not given. That is intradermal. It is just 3 doses they are giving. And they have a data of around 2 or 3 lakh patients, which they are into publishing it. And they are very happy with the results. They are saying that they have not seen any case of rabies.
Okay, I have 2 more scenarios to be discussed. Maybe Dr. Sanjay and Dr. Anurag can discuss. Dr. Sanjay, someone took day 1 vaccine and now comes on day 5. I take the second or day 5. Now, when do I give the 3rd dose? On day 7 or calculate 4 days from the day 2, the second dose?
See, the principle of the immunological reaction after the vaccine is by the 10th day, it should produce antibodies. So if somebody has taken on day 5, I would still give it on day 7.
Correct. Suppose he comes on day 6 for the second dose. Will you give day 6 second dose, day 7 third dose? Does it make any immunological sense? 2 doses back to back on say one day. Or suppose he comes on day 7. Now when will you give the day 7 dose then?
we will give the day
No,
7
these are
dose.
practical questions. These are
Yes,
discussed in our
absolutely.
vaccine group. So
Yeah,
we need an
absolutely.
answer. Unfortunately, ICVIP doesn't have an answer, but there are two schools of thought. Me and Sagar, we both feel that immunologically giving back-to-back has no meaning. Keep that gap of 3 days between the second and third and thing like that. Whereas Anurag and Kasi are very strong saying, no, 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 you just give it back-to-back. So
No, sir, I say that add the number of days. I don't say
add the
back to
number.
back.
Okay, sorry. So Kasi was saying that.
I
No,
think let us not debate on that. 037 is important because that's the most important. So if
no,
somebody,
that's correct. But suppose the day 0 is taken, day 3 comes on day 6. When do you give the day 7? That's the question. You give it after 4 days, right?
Yes, so
Yes.
that is
Between
what
the
we
second
follow.
and third dose, you keep a gap of 4 days
Yes,
as you would have
yes,
kept originally. Is that
yes.
correct?
So if he comes at day 6, the day 7 days dose goes to day 9,
Correct.
9 or
Perfect.
10, whatever. Yeah.
And then the
So
last dose will be anywhere little later.
every you add the number of days. That is
Correct.
what we
Perfect.
follow, sir.
I think Sagar is happy to hear this. Sagar?
So, sir,
All
we have
right.
done
Okay.
again multiple trials for various products, and therein we have this situation scenario.
Correct.
And number of days he comes late, we add the number of days.
Perfect.
Simple.
And the second scenario is that someone has started taken pre-exposure day 0 and day 3 as per day 0 and day 7 as per IAP schedule or WHO schedule, and now he comes on day 8 or day 9 with exposure. Anurag, what will you do? You will calculate.
So,
You will take it as a null and void pre-exposure and restart.
so it is a very difficult question, and multiple answers are there. So
No,
when he
practically, what
comes
would you
on,
do?
yes. So when he comes on day 8 and he has taken 0 and 7, now we are in a bit of a soup what to do, because antibodies develop from 7 to 14 days.
Correct.
After day 14, we are sure nothing needs to be done. Just continue the schedule
Correct.
you are giving. But herein we are in trouble. So I look at the severity of the bite, and if it is severe, I give immunoglobulins. And if it
Yes,
is
yes.
not severe, a simple scratch or something, I can simply tell him, okay, nothing much needs to be done, because after day 7, antibody titers start coming up. But
Okay.
I veer more towards giving immunoglobulin till 10 days.
No,
After that, we can.
So the
Till
question
10 days.
Dr. Kasi used to mention that when you give post-exposure day 0, 3 and 7, it will have a good antibody by day 10 to 14. But when you give
Yes.
only 0 and 7, it may not be enough. So probably
Yes.
you need to give 2 more doses.
Vaccine we will be giving. The problem is
No.
monoclonal antibody.
No, monoclonal, of course, you'll give. I'm saying vaccine. Will you give how many doses? Like 4 more or 2 more?
No, sir. We will count those 2 doses given initially and
Okay.
add 2 more. Because
All right.
he
So,
has received 2 doses, na?
yes,
So
correct.
4 doses
All
are, it is no sense giving 6 or 7 doses unnecessarily.
Correct. So the question was that once you're given a pre-exposure prophylaxis on day 0 and day 7, when does the protection start?
So
Suppose the bite is on day 15
by,
after that, day 20
by
after
day
that.
14, titers come up, sir.
By 14. So anything
Yes.
after 14 is a valid pre-exposure. You will give only 2 more
Yes.
doses. And if
Yes.
it's before 14, you would add those 2 and maybe 2 more.
Yes.
This almost remains the same, that you actually complete 4 doses.
Yes.
All right, perfect. Any question now from the audience
And
or
sir,
anyone?
yes.
Yes.
There is another caveat to it. Ask the family why is the child is being bitten by dogs so frequently.
Yeah, correct.
Maybe
And
the dog is violent or the child is abusing the dog.
correct. And Dr. Khadke mentioned that for category 1 bite, you don't need anything, but that's a reminder that you are likely to be exposed to rabies or dogs or cats. So you take your pre-exposure. So I think that's the good time to sensitize them to take pre-exposure prophylaxis. All right, Dr. Sanjay, you wanted to say something before we open the question answer to the audience, you
no,
said?
just before this session, I got a call about 10
Uh-huh.
minutes before. A mother rang up saying that one of her adolescent child had taken 2 doses of TH rabies vaccine, and the third dose is not locally available. So I said, give whatever is available, but I wanted to take an opinion from Anurag actually. Just about 10 minutes before this
I would
session.
give 2 more doses.
I would restart the schedule, because we do not know about TH rabies much. And if it is adolescent is below 18, that
Correct.
product is not recommended at all.
Correct. 2 funny incidences. One fellow asked me, does elephant bite need rabies? I said, yes, provided you survive the elephant bite. And the
Definitely, I
real thing
agree.
that happened in Gujarat, and in fact, it's come in the paper, that a lion bit a child. And somehow the mother or whoever was there, they drew the lion away. So the child survived lion bite, but there were multiple bites. And again, as we discussed, we need to cover all the bites with proper dilution, antibody, and give vaccine, and that child survived. All right. Any question?
I got a similar scenario from Jim Corbett. A tiger scratched severely a person, ranger, a
Oh
ranger
my.
who works there, and
Yeah.
he had to be given. They sent me a photograph. I said, you infiltrate and give the vaccine.
Perfect. I think we can open the, we have another 5-10 minutes. We can open the questionnaire to, I see a lot of experts who are here. Dr. Sagar is there. Anyone else wants to ask a question? Please unmute yourself, feel free, or any comments you want to make. Sagar. Yeah, please unmute yourself. Hello, admin, please allow everyone to unmute.
There is a
Admin?
question on rat and mongoose bite. So
Yeah.
if it is in your house, you
Yes.
don't need to do anything for the rat.
Correct.
If it is in the wild, you give the complete course,
Perfect.
and mongoose, you give the complete course.
Perfect. Anyone from the admin side, Maharashtra admin, please allow Dr. Sagar to unmute.
Pallavi madam, please unmute.
Allow
If there
everyone to
are any
unmute,
questions on the
please.
chat, we can take it from the chat also.
Okay, yeah. Okay, let's see. Chat box, there are questions. Pakmode Sahib, jara sanga na kon hai admin. Allow everyone to
पल्लवीला
unmute.
सांगितले सर
हा.
पल्लवीला सांगितले
Sagar, unmute करा बघा. नाही होत. Okay. Chat box मध्ये question आहे. अमोल किंवा पाकमोडे sir.
Acha, Dr. Manish is asking 3 months from the first dose or the last dose. So we had a huge fight on one of the groups, and I, in fact, referred to the person whose review article gave this recommendation of 3 months. So the problem is that when we collect data, we do day 90, and we do day 90 from the first dose, not from day 28.
Correct.
So it is the first dose, sadly, which we have data, and that is the recommendation. In fact, the person who published the article in 2012-13 on which the WHO based its guideline, he also was initially surprised. Then the team which published the paper got together, had a discussion, and they said, I'm sorry, it is from the first dose.
Correct. So if you have used 03714, you have another 2.5 months as the window.
Yeah.
Till the time re-exposure is
So
not
it is from the
required.
first dose, simple as
First dose. Perfect. 3 months from first dose. I think that makes sense. Is Dr. Sagar allowed to unmute? अरे क्या है कोई नहीं है क्या पल्लवी मैडम कुठे है
Sir, questions the chat box में और देख लें कोई
Sagar,
दिख
can
जाए
you
तो।
put in chat box? Okay, he's put in chat box. He's saying, all right, let's see.
Pallavi madam, please unmute.
Pallavi madam is
How
sleeping.
about monkey bite? Monkey bite, it is same like dog bite. Treatment remains the same, and there is no observation or anything period in that. You treat it as the same.
Okay, Sagar, I can't see your question. Sagar, okay, 90 kg obese does dose of HRA. I think there's no ceiling to dose of either
No upper
molecule
ceiling.
or...
It was there till 2014. After that, WHO removed the upper ceiling. You multiply by 20 or 40, whatever you are giving, and then look at the wound size. As per the wound size you give, and the upper limit is the weight into 40 or 20 IU, whatever.
Correct. So, Sagar, if you have a 150 kilo and suppose you're giving monoclonal antibody Rabies shield, it'll come to 3.3 is almost like 450, correct? But if the wound is only small, you may need only 0.5, 50 units. So,
Parrot
it's
bite,
not only,
tortoise bite,
that's the
not
maximum
needed.
dose. That's not all the dose that you need to give.
So parrot and tortoise not to be given. Number one. Number two, tortoise is illegal in our country, I believe, keeping at home. So where did you get it from?
No, it may be in wild somewhere or something.
Then it is all right. No treatment required because the body temperatures are different. The virus does not survive at that body temperature.
Pakmode Sahib, hey, chichundri ka hai, shrew.
What is chichundri?
Chichundri is a form of a, is a rat.
It's a rat. Okay, we say no.
So, sir,
domestic rats, no.
It is simple. Other than domestic rats, all rats you give. We don't know what chichundri is. You give it.
Sir, चुचुंदरी को चूहे की मौसी बोलते हैं सर
नहीं बट वो चूहा ही है ना मौसी होके
yes चूहा ही है
bite on nibla you give, bite on tip of the finger, you infiltrate with your insulin syringe, whatever amount, even 0.2 ml is sufficient. See, the concentrations are very high. When you give twin rab, it is 600 IU per ml, and the protective titer needed is 0.5 IU per ml. So you are already giving 1200 times more than the required amount. So when you dilute, you give it even 2-3 drops are sufficient.
Yeah, and when you inject in the pulp, we remember don't inject too much, otherwise it can lead to gangrene. Yeah, I think one thing we didn't discuss that there is a pet dog bite what do we do? And pet is immunized very religiously.
Vaccinated pet dog.
If the pet has never gone out of the house after the pet was bought for last 2 years, then probably there won't be any rabies, right?
Yeah, you're right.
But
So
if
only
it's going
then
and mingling outside, then you can never be sure. When in doubt, give the vaccine. I think bottom line.
Their vaccination. I mean, the
Ah.
schedule is also we don't know.
So Indian dog vaccine, which is given to dogs, is giving protective titers at the rate of around 60% only at 6 months. So better to give it. And better still is take pre-exposure prophylaxis so that you don't land into this mess.
Exactly right. So all pet owners should take pre-exposure for themselves and children, because then they don't need the monoclonal antibody, which is going to be expensive and may not be easily available.
Painful, sir. It
Right.
is very painful.
Right. Okay,
Because
I think any more questions from the audience? Are the audience allowed to unmute now or still no?
there are lots
No,
of questions
not
coming
picking
on
up
this
the
phone.
phone.
I'll tell you one thing. Nitin sir, I've called Pallavi also. Probably
She's not
like,
picking phone.
yeah,
Oh
that's okay.
God. I
So
think
what
she should
we'll do,
make
sir,
one of.
I think
There's one
next
question
time,
mentioned.
next
whether
time tell 1 minute, Dr. Sanjay, tell
sir.
Pallavi next time she should make you the host and go, and
Yes,
not
yes,
do
yes.
like this. Okay.
Yes.
So you were saying something.
With in the one question mentioned here, Revati, Bangalore, whether ARV and immunoglobulin recommended for monkey bite.
No, we said no.
Yes, all
And
but.
especially when the child is taken to a zoo visit, the kid unknowingly puts his hand inside the cage.
Whether it's a provoked or unprovoked, you would give.
Unprovoked.
You
Provoked,
give,
so
sir.
definitely.
There is no choice you give.
Unprovoked, definitely. Provoked, it's okay, but still give it.
Sir,
Sir, we'll take up the last question, that is contraindication to immunoglobulins.
We have discussed it already, sir.
We said now only
Yeah, I think, yeah,
previous.
discuss, yeah.
So that question comes only when you have to use it second time in an immunocompromised. And if there was anaphylaxis with the previous one, then probably you'll be careful. I would still give it under the observation. But
So equine rabies immunoglobulin should not be repeated.
correct.
Because if we remember the type 3 hypersensitivity from equine serum, this is the equine serum they talked about.
Right.
So we do not want to repeat it. Other than that, autoantibodies develop against these serums because they are equine, they are foreign proteins. Actually, there is not a problem. You can repeat it as many times you want. Ideally, you should not need it. If you complete the vaccine schedule, you will not need to give immunoglobulin again.
Okay,
Twin
for
rab,
human
you
bite,
cannot repeat.
human bite, you
Nothing is
don't need
needed.
Always
unless
ask.
from a rabid person. Then
Rabbit
what
person,
else?
yes.
Yes, but otherwise no. Rabid person,
transplant.
anyway, you should be very careful in handling the secretions, especially the saliva. And even if you're doing LP for some reason, CSF can have virus, so be careful about that. Okay,
Sir,
we
I
already
just wanted-
discussed
Sir, I
rebite by
just-
pet dog, cat, category 3, and child vaccinated 2 months back. We already said that
Discussed
it'll
it, sir.
be
Why we are not including pre-exposure rabies vaccination in our national immunization program?
So, sir, I had a half an hour talk on this topic in one of the rabies conferences. I will send you the slides. See, for
this
having
is
a
mentioned in the
vaccine-
chat box, sir. Chat box.
I understand. For having a vaccine in the program, it is not an easy thing. You have to have the product, you have to look at the side effects, you have to look at the
Very true, sir.
window. So, a lot of things have to be
Yes,
discussed.
yes.
I
We
think
don't have
even
that much
if
production.
our public health becomes very active in post-exposure prophylaxis, that will prevent
Yes.
a lot of deaths than trying to
Yes.
break our head on pre-exposure.
So what
Our
is-
coverage for most of the vaccine is never more than 70-80%, and for a pre-exposure rabies is going to be even lesser. So probably that's a very far-fetched thought.
So what is
I
more
have
important is
only
having
one
dog
question.
vaccinations. If you have
Yeah.
70% dogs vaccinated, the chain of transmission of rabies will break and you will not need all these things. One health is the most important concept for managing or
So
preventing
you
rabies.
have all sorts of fancy animals, fox, jackals, which are more important in country like USA and all. In our country, dog and cat still remain the main two.
Yes.
99%
by
is
dogs
because
only.
of dogs. 99% is from
99% by
And
dogs.
who is the
dogs only.
Jaiko? Jaiko,
Yes.
please unmute yourself. You are disturbing us. Sorry. Yeah. Anurag, continue.
So
Sir, I have only one
99% of
question.
rabies. Sir, please.
No, Jaiko. Someone Jaiko. Now
Yes,
you
yes.
Okay, go ahead.
Sir, I have
Anurag,
only
go
one
ahead.
question. We have paid dog. We have vaccinated dog as well as we have taken all pre-exposure prophylaxis.
Correct.
But at the same time, the dog is always playing with the children as well as us also,
Mhm.
and we are getting grade 2, grade 3 not grade 3, but at least grade 2 bite some or the other time. How
Correct.
many times we should repeat our 0-3 schedule after
Every
3
3
months?
months. Every 3
Every 3
months.
3 months. How many times
Sir,
we should reschedule?
Everything.
sir, I will tell you. I will tell you. See, first 3 doses give you good titers, and if you look at data, at 1 year, more than 90% patients still have protective titers. So if you take a booster 0-3, your titers will last even up to 5 to 7 years, 10 years. I'm talking about protective titers, not memory
Correct.
cell. My titer is 1.53, which I did just 1 month ago, and I had taken one booster 1.5 years ago, and I had taken pre-exposure when I was a PG. So you can see the persistence of antibodies. They persist for years together. So
No,
it is
so the
not a
question is,
problem.
Dr. Anurag, that's not, but the remaining 10 who would have lost the antibody, they are at risk. So I think the question is, if you
Yes.
can do antibody titers, do it. Otherwise, take
So
the
yeah,
vaccine.
so I was coming to it. So now we have 3 categories: low risk, high risk, and medium risk. If you have a pet, although you are in low risk, and if you are very afraid, take 1 or 2 boosters and get your titers done every year or so.
Absolutely.
If they are in protective range, nothing needs to be done.
Correct.
Because you cannot take 20, 30 doses of the vaccine, you keep getting scratched by your dog. You will have a hyperimmune reaction. I have seen a few in patients who have some psychological issues. I have seen big patches on their side where they have taken the vaccine. So yeah, there is a hyperimmune kind of a reaction also.
So that is what is actually recommended for the veterinary doctors, that they
Yes.
actually take 3 doses
Titers.
and then do a first booster at 1.5 to 2 years and then do titers every year. Moment it
Every
falls below
2 years,
0.5,
yes.
yeah, they will take a dose of that.
So
Sagar,
best
you want
it
to
is
ask something?
every 2 years for
What
people
WHO
working with
position
mild.
paper says,
Sorry, Sagar?
what WHO position paper says that even in case of bite, even if the antibody titer is 0.5, you will still have to give 0 and 3. So for post-exposure prophylaxis, antibody titers will not matter. For pre-exposure prophylaxis boosters, we will consider the 0.5 level, as there will be no need to take any more pre-exposure. This debate was there on our group also with Umesh Bharti sir also, and WHO paper specifically mentions if there is a rebite, even if antibody titer is 0.5, you will have to take 0 and 3 doses.
So you
So
see,
you mean to say that basically we go on giving 0.3 for every 3 months?
The rules are rules.
Better
That is
not keep the
WHO.
no,
pet.
sir.
So
It is very difficult. If you look at
that is the beauty of, or beauty or otherwise ugly side of this vaccine, that fear of rabies and death is so much that people who believe that no, we stick to the rules and we cannot allow, okay, give vaccine, but there is a practical way that doing a titer if it's more than 0.5 it is protective in the next 15 days, unless you say now after 10 days maybe 0.2 what will happen. I mean, these are theoretical, but I think give uh, 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 when in doubt, give the vaccine.
I think yes, whatever
There
you have
was
said
one,
is
So,
right,
there was
so
one
sir.
question that
Because
I made up my mind of doing titers and seeing that basically whether I should take a 0 or a 3 after that 3 months.
Correct, that's what we said.
So now the Sagar is saying that even if your titers are 0.5 and you still want to give, then how many doses I am going to take in throughout my life?
So Sagar will keep on giving. Dr. Anurag says that I won't give. And then,
one
these
question
are
was
gray zones.
unanswered in
These
the
are gray zones in rabies vaccine. There's nothing
so
100% because there are no such studies available.
sir, what
one question
again
was
is
unanswered in the panel, that if
uh,
a child was given post-exposure, let us say around 20 years back, now he has come, will I rely on the antibodies or will I complete the 5-dose schedule?
If he's not
you will,
immunocompromised, then
sir, yes,
probably there will be
0-3
anaphylaxis
are sufficient.
response. Yeah.
Yes. See,
Even
these
after
are
20 years
very,
of
very, so see, the memory cells are very good with this vaccine. And we have 25-year data. And you look at my example. I took the vaccine when I was a PG 25 years ago or 30 years ago. I took a booster 1.5 years ago, and I did my titers just around 15 days ago. I'll send you the report on the group. You can read the report, and I am protected still. So let us not be afraid of rabies to this extent. Any person who has received 2 or 3 doses of the vaccine is protected as such. Yes, exposed, take 2 more doses so that you are sure of what is happening. Otherwise, don't be that afraid. Important thing is wound washing, immunoglobulin, and post-exposure prophylaxis, that is vaccine to be given in case of exposure.
So
In fact, the WHO paper goes on to state that shortened courses, 1 dose
Yes,
That's
The
what I
study
was
from
coming to.
Belgium.
So
So,
Dr.
it is-
Anurag, there was a study to say that can you give just one dose and prime everyone instead of giving 2 or 3 pre-exposure? So that then again re-exposure only 2 may be enough. I mean, is there any solid data on such study beyond that one study?
Yes. So there was a meta-analysis published around 2 years ago, and I conducted a thesis research, and my data has just come 5 days ago. And after one dose, day 28 seroconversion was around to the tune of around 85 to 88%. And when I gave them boosters, the ones who had not seroconverted, 2 doses, there was 100% seroconversion.
Correct.
Then I looked at their titers at 6 months, 180 days. And at 180 days, around 67% still showed titers, those who had received one dose. And when the persons who had seroconverted to negativism, who had shown titers below 0.5, I gave them 0.3. At day 7, they showed beautiful titers. So one dose is also good because our aim is priming the immune system, priming the memory cells, not looking at titers.
Correct. So this 0, 3, 7, 14, 28, 0, 3, 0, 7, all schedules have been found in the past. No one will dare to challenge it. Just use it. But the bottom line, the immune system is much smarter than us and doesn't discuss as we are discussing here. If someone is primed and immunocompetent with 1 or 2 doses in the past, another 1 or 2 doses should be enough to see him without any rabies. I think we will conclude with that. Dr. Pakmode.
Yes, sir.
Yeah, Anurag, last comment. Yes.
So what I was telling Dr. Sagar was that you talk to Umesh Bharti, he will tell you stop counting. Yeah, it is tiring. You pediatricians count too many doses. Don't go and fall into that trap. Keep counting.
Sir, one last question.
Sir,
good evening, sir. Sir, one last question I want to ask.
Bolo, Pankaj.
Sir, do we need to document seroconversion after taking 2 or 3 intramuscular doses?
Unless you are immunocompromised, no.
Yes. Unless you, sir is very right. Unless you're immunocompromised, no. And even if you document an immunocompromised, if you get an exposure, you'll have to take the complete course.
Including
because you cannot keep
immunoglobulin.
documenting it every week or 15 days or a month.
That and plus the anamnestic response may not be as strong in immunocompromised.
May not be as strong. Very, definitely.
All right, I think we have had a very lively discussion, and I'm so happy that we discussed threadbare, including the gray areas and some semblance of order to guide a pediatrician. And when in doubt, ask one of the experts. And when in doubt, give the vaccine. I think these are the 2 messages I will want to give at the end. Over to Dr. Pakmode to conclude the session.
Yes.
Or Minaz, whichever, whosoever.
Yeah. Thank you, sir. We are 43 past 10 p.m. on a very auspicious day of Teachers' Day as well as Eid Milad. So again, as expected, has been excellent discussion, moderated by our own Nitin Shah, sir, and aptly, discussed with Rampur, sir, who has been to the point, and I would say Anurag, sir, the data man. For every question, he has the data. And would like to have the data. I mean, data has always been impressive, and not only data, is clinical acumen as well. So also the our own Khadke sir. So lot of discussions and lot to learn. And thank you all. Thank you attendees. We have 200 plus attendees tonight. Thank you Pallavi for being with us always as a technical support. We'll meet again on October 3, as sir has rightly said, on adult vaccination, which is a new horizon coming in, which is most of us are, required to have it. And most important is that these all sessions are available on MyIP YouTube channel. You can go and look the same session whenever you need it. So once again, thank you. We wind up this session. Good night. See you again on October 3, first Friday of the month October. Bye.
Thank you, Nitin Shah, sir. Good night. Sanjay Shriram.
Thank you, sir. Thank you.